All right, cool. Welcome to week 6. I
Yay.
can't believe it's already week 6.
I know.
That's crazy to me.
I
Uh,
can't believe November's going so fast.
yeah. Yeah. It's already the holidays. Do you guys tend to, how early do you guys decorate for Christmas?
Well, I usually try to do it right after Thanksgiving and get my grandson or my granddaughter to come over and help me. I don't know about this year. I would like my grandson to come get my artificial tree for me. He and I went and bought a new tree 2 years ago. And sometimes that's all I do. I used to do a lot in the house, but now my daughter has everybody over for Christmas, so I don't really have the
Oh,
family like I used to. So
yeah.
that's okay. I'm old. I don't mind going somewhere else and just bringing kids.
Yeah.
I'm kind of in the same boat. I don't decorate a lot. For one thing, my cat, this this
Oh,
this cat, I've never been able to have a tree because she just rips them apart. So I get a little artificial one that I put up way high. And
oh.
I put a few things out, but it is different. Once the kids are grown and you're on your own, and I can't get up on a ladder and put up lights. I wouldn't do that anyway. So
I
Yeah.
don't, yeah. I just do mine on the bushes in the front. And then I have a thing that shows red and green on the house, I
oh
can't,
yeah.
like a kaleidoscope or whatever, and that's easy for me. But I really like my grandson helping me because I don't have to do as much. He hangs everything. But they're
Nice.
so busy with school and sport. Although he's been real sweet the last couple of years to come and help me.
That's cool that you have a good relationship with him. All right, so we are going to start now. Let's zoom out for a second and talk about a fall prevention plan. A comprehensive fall prevention plan usually will start with exercise, home safety, vision, and medications, and then all of the risk factors after that. And so we've talked about exercise, we've now talked about home safety. Did either of you do the home safety check?
I have not,
No? Okay, just curious.
but I
No.
will.
Well, I did that when my husband had the stroke. I had to do a lot of things different and I haven't changed any of that. So
Okay,
I'm in pretty good shape on that.
I
cool.
think I'm in pretty good shape too because I did so much after my big accident. So
Yeah.
Gotcha.
should
Yeah.
be pretty safe.
Yeah, if there's no immediate concerns, like you would know if there were immediate concerns, so then it might not be the highest priority. Might be good to go through just for thinking about 5 or 10 years down the
Yeah,
road,
right.
but
Yeah.
again, might be when we're planning. So in 3 weeks, on our last week, we'll kind of look at everything that we've talked about and say, is there anything I want to take action on? And if so, what is the top priority? 1 to 3 items. So no more than 3 because we don't want to get overwhelmed. Most people, I just recommend 1 or 2. So that might not even be a thing on your priority list. So we've covered exercise and home safety. Now today we're going to start going into medications and vision and a couple of the other risk factors. So if you want to follow along on the screen, you can do that. If you want to follow in your book and take notes, it will be page 62 for module 5.
Can I look at the screen?
Yeah, I'm going to share it right now.
Oh,
Do you
good.
see it there?
Yeah, perfect. Yes, thank you.
Cool. You're welcome. Okay, so first we'll talk about medications. I am legally, as a physical therapist, it is out of my scope of practice to give any prescription advice, any medication advice. So that I have to have as a disclaimer. I can technically not even recommend that you go take an Advil or a Tylenol. Isn't that silly? So, I get why they do it though, and there's a lot of liability issues. And so, all of what I am going to teach on today is educating you on how to research better on your own and or advocate for yourself better with your pharmacists and your doctors. Okay, it's kind of like teaching you what questions to ask and not just as it relates to fall prevention. And before we go into this, I had someone ask me a really good question one time, which is like, some of these medications that increase your risk of falling decrease your risk of other really important, potentially life-changing things. So, should I not take my blood pressure medication because it's putting me at higher risk of falling? Well, no, I'm not saying that. I am, again, educating you on how to have better conversations with your providers so that you can make the decisions that are best for you and trust more and just be kind of more an active participant in your care instead of like what we've all done. And I feel like I just recently did this. I can't remember, sometime in the past year or two. Oh no. Where a doctor gives you a medication, you take it without question, right?
Mm.
You don't ask questions, you just, okay, they told me to do it, I'll do it. So this is kind of encouraging you to think for yourself and not just be pushed through the system and blindly take whatever is given to you. So with that, in the past, they used to define, they used to say that you are at a higher risk of falling if you had what's called polypharmacy. So the definition of polypharmacy is simply taking 5 or more medications. So they said it had a correlation with increased falls, but it's not an independent risk factor. So there is still a correlation with increased falls, but it is not like a cause and effect. They define excessive polypharmacy as having 10 or more medications. Now what they're saying, they've done more research saying it's not so much the quantity of meds that you're taking, but the type of meds that you're taking. So now they have a new category of drugs. It's not a category, it's not like a class of drugs, but they've done research as it pertains to medications and fall risk. And they have come up with a group of drugs that do increase your fall risk, and they have nicknamed them fall risk increasing drugs, or FRIDs, FRID, FRIDs. So they have now done research saying that taking 2 or more FRIDs is associated with increased fall risk. So this includes cardiovascular meds, central nervous system meds, pain relievers, analgesics, and endocrine or hormone drugs. So you might have heard antihypertensives, antipsychotics, antidepressants, SSRIs, benzodiazepines, anti-anxiety, narcotics for sure, anti-Parkinsonians, anticholinergics, anti-diabetics, and sedatives. So what a lot of these have in common is that they either affect your blood pressure or they alter they're mind altering, like an antipsychotic, or they make you drowsy. So if you're sleepy, it makes sense that you'd be at a higher risk of falling. So because you're kind of out of it. With antidepressants and stuff like that, that's interesting because depression is an independent risk factor for fall risk. So if you are depressed, you do tend to be a little more removed and detached from your environment and little lower energy, maybe not moving as fast. So that can increase your fall risk. So that's why I say, I've been personally impacted by people with severe mental health issues that absolutely needed medication. So it's like, this is where you weigh the risk of taking the drug versus not taking the drug. Is it better to have antidepressants on board and help treat that? and accept a little bit of fall risk? Or are you gonna try to treat the depression in other ways and decrease your fall risk? If you need medications, so, you don't have a heart attack, but it increases your fall risk, it's probably more important to take the heart meds. You know what I mean? So, these are the conversations to have with your doctors. And then I see it so often where people are on 2 or 3 blood pressure medications. And it's like, okay, can we now have a conversation with the doctor that how can we get down to one medication that's doing the job of all 3? A lot of times the doctors aren't even aware that you're on multiple meds because maybe your primary might start you on something, then say you have a cardiologist, but then somebody else adds something, or maybe this is a big one, you get hospitalized
Mm.
because of a cardiac event. They have to give you drugs, and then the person just goes home and keeps living life and doesn't follow up with their cardiologist right away. And then again, people are just kind of they don't mean to. I was this way as well. I was just kind of blindly going through the healthcare system, taking what was given to me without questioning anything. And so if you can't take out a medicine, can you reduce it or at least decrease any redundancies? Those are the questions you want to ask your doctors. I personally think the more opinions, the better. You can't ask these questions too many times. I would just get literally everyone's opinion. They've all been through medical school. They all have a different lens that they come at this with. And you might not think that your dermatologist might have any good things to weigh in on, but who cares? Ask your dermatologist. Ask, but the main ones that you want to ask are definitely your pharmacist, because that's where I would start. You can take a list of your medications, and if you don't have a list, I would recommend making one that's hopefully typed up, because I've come across a lot of them that are hard to read. And then once you have it typed up, it's really, really easy to go in and update it. If say they change something from 5 milligrams to 10 milligrams, you're not going to want to write out the whole list again. So you can just go type it and reprint it. So you can either take the list in, or you can just take an entire bag of all your meds, just throw them in there, take them to the pharmacy and say, hey, can I have what's called a pharmacy review or a medication review? And they will go through all your meds and say, are there any they have different levels of rating the interactions that each drug has with each other. So not only does each individual drug have an impact on your body, but once you add a second drug, those 2 drugs can interact with each other. If you add a third drug, each combination can interact with each other. So now you have 3 different interactions going on separately, in addition to each independent interaction in your body, if that makes sense. So it can get crazy as you add more and more. So they can just say, hey, these drugs are known to have like a medium reaction with each other. This one's severe. You want to really be careful combining, how they say, like, don't drink alcohol while you're taking narcotics, stuff like that. And then you can then go on to ask your primary care as well as any specialist. So pharmacist, primary, and then any specialist that you have. And then these are also good questions gearing up for surgery, definitely to ask them. And then the second resource that I want to give you guys. So the first one was the FRIDS, Fall Risk Increasing Drugs, FRID. The second one is called the Beers Criteria for Potentially Inappropriate Medication Use in Older Adults. and this is from the American Geriatric Society. So it's spelled just like the drink beer. So the beer's criteria, you'll often hear it just simplified as that. So this is a lot of research was done and list of medications that are typically best avoided by adults 65 years and older across all settings of healthcare. So they are looking at people that are still living at home, they're living in assisted living, independent living, skilled nursing, memory care, hospital setting, just all the settings. Healthcare providers can use this list as a guide to do no harm. It's revised every 3 years, and there are 5 sections. So medications to avoid if you're over 65 years old and not in hospice or palliative care. So that means, you're still going for recovery and healing, and medications to avoid among people with certain health conditions, medications to avoid that cause drug interactions when combined with other medications, medications to avoid due to harmful side effects that outweigh the benefits, and medications to use at limited doses or avoid due to their effects on kidney function. So those are things that you might be interested in. You can simply type both of these resources into Google. You can just type Beers criteria and pull up the research paper right there. You can see it as a PDF. You can print it out if that's easier to read. You can also do the same with the FRIDS and just read. Some of the resources are easier to read than others. They're more in layman's terms. Other things you may find if you have a difficult time getting information that way is just to look on YouTube and find people that are doing like lectures about this stuff. You can also print these out and bring them right to your doctor and say, hey, doc, have you seen this paper on fall risk increasing drugs? I'm really doing everything in my power because, XYZ. So just a lot of different ideas to have a little bit higher level conversations with your doctors. And if you know that this is not a forte of yours, then recruit someone whose forte it is. Have a friend go with you, a family member go with you that is a researcher. We all have a certain friend and family member, I can think of them right now, that's just a researcher and really good at that naturally. So if this is kind of intimidating or overwhelming, just ask someone for help. So any questions on any of that so far?
I have one question.
Yeah.
Hypotension. What is hypotension? I thought I had hypertension.
Okay, hypo is low blood pressure.
Ah, okay. Okay, thank you.
You're welcome.
I see my doctor once a year, and I'm seeing him this month. I really only take one prescription, and I'm assuming all these meds are prescriptions, right? But I do
They
take
don't have to be. A lot
I
of
take a lot of supplements, and I always go, and I have a lot of questions this time on those things. I want to make sure I'm not taking something I really don't need as a supplement.
Yes. So do you have a typed up list of every medication and supplement that you take?
Oh, yeah, and it also has my shots that I get, like flu and RSV and all
Okay,
that.
cool. So yeah, certain supplements. So what we've talked about is mostly prescription drugs. Yes, to answer your question. However, I'm so glad you said that, and I should make a note to add this for the workbook, is that if you think of there's natural drugstores with tons of different, more holistic supplements that can help you sleep better. So if you're taking a supplement that makes you drowsy, that would increase your fall risk. So it doesn't just have to be prescription. So that was a great question. So let's see, we have probably touched on most of this. Educate yourself. These are potential things you can do with this information. Educate yourself about the basics of your medications and supplements and the side effects it has on your body. So even if it says, oh, it may cause drowsiness and heart palpitations, if you've taken this medication for 10 years and never had drowsiness or heart palpitations, you're probably good. So how does it impact your body? Ask your doctors to slow down. And if I have a hard time doing this sometimes, but especially now being in healthcare, I try to force myself to just ask again. Oh, I still don't understand. Can you explain it a different way? Now, pretend like I'm a first grader, please. Like, I don't understand they just accidentally talk with medical jargon because it's faster and easier. And nowadays, not every doctor, but a lot of doctors they don't spend as much time with you as we would like. Some doctors do, and that's wonderful. Always grateful for that. But if you're feeling rushed, try to combat their energy and just slow them down and say, this is really important to me. I'm only here once, like, just ask for what you need and don't let them push you around. I've become very passionate about helping people to advocate for themselves in the health field because it's kind of unnerving. Like, I went to the dentist last week and it's different being in the patient seat. It's a little, I don't know. So, make sure that you know exactly what they're telling you. Do your own research, get blood work before and after. So don't just take vitamin D just because, but go based off your lab work. Say, vitamin B, all the deficiencies and stuff like that. We talked about which risk is greater to you, keeping an up to date. Okay, we've mostly talked on this. Let me see.
I learned with my husband after 20 years of a stroke and 3 open heart surgeries, we asked a lot of questions. Did dress down one neurosurgeon. He was a young man, and I always have a list of questions. And my personal doctor, he always is kidding me, and he says, "Do you want to go first, or do you want me to?" And I said, "You go first. You're the doctor." But this young doctor, my husband was in ICU. He had brain surgery, and I told him I had some questions, and he said, "I need to do such and such." I said, "That's fine. You do what you need to do, but you got to answer my questions." And he evidently
Yes.
told the nurse, because when I called during, at 3 a.m. to see how he was doing in ICU, she said, "Did you dress down Dr. So-and-so last night?" And I said, "Well, I kind of told him a few things." And she said, "Yeah, he told me you did." But he was a young guy, and he's got his MD, and I had questions, and my husband almost died, and I wasn't fooling around with him at that point. So I've learned that if you don't advocate for yourself, I've been fortunate. I have good doctors. He was filling in for my regular surgeon that night because he had gone out of town. But
Well, good for you. I bet that lesson stuck with him.
I guess it did. He told the
Yeah.
nurse. So anyway,
And you bring up a good point. Thanks for sharing that, Bonnie, because I have also started teaching people or recommending to get either some kind of notebook. It could be spiral bound, it could be 3-ring binder that you can take papers out and in. But working with the population of people that I work with, a lot of people will have some kind of event where I've just seen this so many times. There's a year or two where their life is consumed by doctor's appointments. It's like they are exhausted and their whole week is centered around which doctor are we going to today? And it's just crazy. So I really recommend keeping a notebook where you don't have to keep a lot of notes, but November 4th, cardiologist, name of the doctor. So many of my people don't even know the names of which doctors are which specialists. And I know. And so it's like, how are you going to make any forward progress with your health if you don't know who's telling you what and you're not writing any of it down? So, the paper, just like Bonnie was saying, is perfect to write down all your questions before you go in so that when you're in the hot seat, when you're having this conversation with the doctor, that you don't forget anything. I have been to doctor's appointments with my patients, brought a list, and I almost forgot to ask all the questions because the conversation naturally flows and then it gets away from the third question on your list and you almost forget to ask it. So that can be just really helpful for staying organized before and after. So even though I do recommend ask all your doctors on their opinions on your medications, most people do tend to have one doctor that is their go-to, like that they trust the most. Sometimes it's your primary, sometimes it's not. So especially some of my people with either cardiovascular issues or neurological issues, they tend to have maybe their specialist is like their go-to person. So and then really, if you don't trust a certain doctor, you can tell that they're kind of giving you a vague blanket answer, not really taking interest in you personally. I would find a new doctor because you want to feel like they care about you and are actually listening. If you are hospitalized, report that to your doctors, schedule a follow-up as soon as possible after so that they can review any medications that were added. And then take your medication as directed and don't skip doses. If you are tempted to skip doses, then that means you probably want to have a conversation with your doctor. I see this too with blood pressure medications where like you should be instructed to take your blood pressure regularly and kind of know where it's at instead of just blindly taking blood pressure medication forever. Because a lot of people will let time go by not checking their blood pressure at all. And then either it's too high or too low and either they're taking medications unnecessarily or the medication is no longer working like it should and they really need to increase the dose, but they have no idea because they've never been checking their blood pressure. So it is a really good idea if you do have blood pressure issues to monitor that and bring that to your doctors as well. So any last questions on meds before we go into the next one?
I've been able to, on my own, wean myself off a muscle relaxer that I've been on for 2 years since I had my back surgery.
Yay!
Yeah, it's called baclofen. I didn't take it all the time, but when my back would had spasms, and yeah, I don't need it anymore. So that's one less medication going through my kidneys.
Yay! That's so awesome. That's so good.
What about blood thinners? What is their impact, do you think, on balance and fall?
That's a good question. With blood thinners, that's mostly talking about the coagulation. So it's not necessarily messing with the volume the way that blood pressure meds are. So the reason like volume is so important because, well, if your blood pressure gets emergently high, that can obviously cause, heart attack, stroke, falls, anything like that. And then if it gets too low, if you stand up and your blood pressure drops really quick, that causes lightheadedness, usually dizziness. You can fall over that way. Other medications that mess with the volume of fluid, like diuretics.
Mm.
That can put you at increased risk of falls. So those are more playing with the volume of water in your body, whereas blood thinners are going to be more for like if you have either like a heart valve issue or you know, any sort of, what's the word I'm thinking of? I think it's going to have less of an impact. Let me see.
I know that
The one
blood
I wanna-
thinners can affect, I want to say like your stamina, like it's harder to climb stairs
Yeah.
and harder to walk real long distances and things like that, having to do with
Yes.
breathing, I think.
So that's a good point of like fatigue and energy.
Yeah.
I was looking up what anticholinergics are. Those are more messing with your neurotransmitters in your central and peripheral nervous system. Do blood thinners. Let's ask Google and see what it says. Increase fall risk. This is saying yes, it can
Okay.
increase your fall risk. Um, it's saying that it can make falls more dangerous. So the reason is
Oh,
like if you were to fall, I've seen people get huge hematomas from a
yes.
fall, or you know, so if you
Because
do,
your blood is thinned out, so it's,
yeah.
and if you cut your head or something, you could bleed out. Okay.
So it's in my mind, let me just skim this. Cognitive impairment, the combination of blood thinners and cognitive impairment can greatly increase the risk of falls and severity of injuries. Um, so this is saying yes. And then also now I'm remembering there are certain hospitals that I worked in that if people were on a certain blood thinner or a certain amount, they were overly cautious and didn't even want you to walk with them. And I thought that was always too far, but they were saying if they did fall and were on a blood thinner, that they could break something or like say they hit their head while on a blood thinner or something like that, then that I think the risk of injury when if you do have a fall could be more severe. So that's a great question. All right. Any other questions about meds? Hey, Carol.
Hey, finally made it.
Woo. All right. Now we're going to go on to vision. Carol, you can follow on the screen or on your book. We are going to page 64. So we're
54.
64. Yep. We're going to talk about these next things. These are all health related things. I'm sure you are well aware of all of these issues, but I want you to think about how it relates to fall risk, especially fall risk in your body. But with some of these, it might not impact you, but you can maybe think of a friend that has had this issue. So vision is one of the biggest sensory systems in the body that impacts your balance. So I believe we talked about this on day 1 or day 2, but there's 4 main things that go into your balance. One of them is motor versus sensory. The other 3 are more sensory. So motor function means movement. Sensory is more like perception and sensing. So the big motor one is just simply your strength and your skeleton, your skeletal system. The 3 sensory ones are vision, your vestibular system, which is like your inner ear, and then your somatosensory is the fancy name. That the easy way to think about it is the sensation, especially on the bottom of your feet. So say that you have numb feet or you have neuropathy and your legs are always burning, that's going to greatly impact your balance. So again, that's vision, vestibular, and sensory, or feeling, especially on the bottom of your feet. So proprioception is another one in the sensory category that you might have heard before. So vision, if you think about it, makes sense when we go hiking, for example, or walking over tree roots, or we're walking on gravel. You can bet you're looking at the ground to make sure you know where you're stepping, because now we have a new balance challenge. So vision at night, also, if you think about trying to walk to the bathroom with your eyes closed and it's dark and you're trying to feel along the walls, like your balance is going to be different. So vision plays a huge, huge impact on your balance. Some things that can affect us are blurry vision, double vision. Our peripheral vision decreases over time as we get older. Glare, I had a woman that had the eyelid surgery, and ever since she's had that, she has had a massive issue with glare going outside, and she's tried sunglasses, and I'm like, you just need to get like ski goggles to go outside, because she just has a real issue with that. Another one is depth perception. So I have a friend in her 70s that has always had this issue. It's not like it only happened in older age, where going down the stairs, whether it's a flight of stairs or just stepping off a platform, she has the worst depth perception with that. And it really, really, it causes like severe anxiety in her. And she really has to breathe through it and hold on to something and make a plan and just go really slow anytime she comes across stairs. So cataracts, these are just different diagnoses that you could have: cataracts, macular degeneration, glaucoma, diabetic retinopathy. A field cut means like your whole field of vision is affected. So when you look out and you have your entire field, is what it's called, like the entire area that you can see is the field of vision. So some people after a stroke, for example, half of their field of vision is cut and they can only see to the left. So that's what a field cut is. Something, this one makes me giggle, but dirty glasses. When I was a new grad, even well into my career, especially when I first started working in skilled nursing homes, I just never thought, it didn't cross my mind to clean off people's glasses for them. And I noticed over time, like nurses paying attention to this. And then I just thought how irritated I get if I have a little fingerprint on my glasses, and here these people are with their glasses haven't been cleaned in 2 months. So that one, it just makes me laugh. But these are people to consider adding to your team if you are having a vision issue. If you really are having a severe issue, Lighthouse of Florida is an excellent organization that can help with adaptive equipment. They can do assessments, they can do training with different walking devices and lighting and magnifying glasses and audio, audio books, and get you signed up through the library and stuff like that. So vision is a big, big one. Any questions, thoughts, comments on vision? All right. Orthostatic hypotension, fancy words here. So orthostatic means basically position changes, is the easy way to think of it. And hypotension is, hypo means low, and tension, this is your blood pressure. So most of us are used to being told that we have hypertension, which is high blood pressure. Orthostatic hypotension is not just resting low blood pressure. That would be a separate issue, just I have chronic low blood pressure. This is specifically with position changes. Another way to call it is postural hypotension. So this is a type of low blood pressure that occurs with position change from lying to sitting, sitting to standing, or lying to standing. So this is when you hear people saying, okay, when you sit up, pause for 30 seconds, sit there a minute, breathe. You'll know if you have this oftentimes because you might have lightheadedness, dizziness, or if it's so bad, people can even faint from this.
Hmm.
Especially if they already have like chronic low blood pressure and then they have this on top of it. That being said, people don't always have symptoms from it, so they can get by for a while, but once it becomes symptomatic, then that's when we really need to do something about it. And this can be acute or chronic. So a lot of people will get this if they've had a surgery or been in rehab or, had some event that they were ill and on bed rest for a few weeks. And then once they start mobilizing again, it's like an adjustment. And basically here, let's talk about the assessment and then I'll touch on why that's happening. So the assessment, you can do this on your own if you have a blood pressure cuff. It's very easy. You literally just follow the instructions. So you would lay down for 5 minutes, take your blood pressure and your heart rate. Then you would stand up and repeat the measurements after you've been standing for 1 minute and 3 minutes. So a drop of blood pressure in 20 points of the top number, or I forgot a word there. This should say a drop in systolic blood pressure, which is the top number. 20 points on the top or 10 points on the bottom is probably just an easier way to say it. So say that your resting blood pressure is 120/80, and then you stand up and it's 90/70. So the top number decreased by 30 points. So that would be a positive test for orthostatic hypotension. Same thing if it goes to 105/58. Oh no, sorry, we're 80, 68. So if the bottom number drops by 10 points or more, that's also a positive orthostatic hypotension test. Does that make sense? Does everyone feel confident in doing this test if they want to do it on themselves?
Yes.
Okay.
Yep.
So a lot of this is, if this is positive, it has to do not only with your heart strength, but also all of our blood vessels have these little receptors that contract to increase our blood pressure when they need to and dilate when they need to relax and open up our arteries to lower our blood pressure. So a lot of this issue is related either to your heart or your vascular system. And like we talked about with bone density, the tissues in our body respond to the stresses that are placed on them. The tissues in our body respond to the forces that are placed on them. So if you're laying in a hospital bed for 3 weeks, your heart isn't getting challenged like it usually is. Your lungs aren't getting challenged like they usually are. Your urinary system, your stomach, so your digestion is going to slow down. You're not going to be pooping as much, So every system in our body is going to respond to the things that we're doing to it. So when we go to resume activity, the heart and the vascular system are just a little slow to catch up sometimes. And so when we go from a laying down position, if you look at this lady laying down here, you can see her heart has to pump blood to her feet, her toes, all the way up to her head, her fingers. And it's really easy on a plot. She's flat, she's horizontal, so she's not having to do anything against gravity. And whereas then when you stand up, Now your heart has to pump strong enough to get it down to your feet, but also to return it back up and to get it all the way to your fingers. And so a lot of times when you stand up, again, if those blood vessels are kind of like slow to engage, all of the blood is going to pool at your feet because gravity is just going to pull it down there. And it's going to take your body a couple minutes for it to, your circulation to get flowing like it should again. So that's a little bit on why that can happen. The treatments can be usually just more activity is the one to start with, but then they have TED hose, like compression stockings, that can kind of not let the blood pool down there as much, and it kind of gives some resistance against your arteries and does some of the job that your arteries aren't doing. So it provides compression there, so it can, I'm trying not to get too technical here, but I feel like I'm going too deep here. So compression stockings, they make it easier for the blood to circulate if your body can't do the job. And then in very extreme cases, there is medication that people can take for low blood pressure as well. Then going on to dizziness. So I like to ask people when they tell me if they're dizzy, can you explain it using different words? Because there's a lot of different types of dizziness. There can be lightheadedness, imbalance, nausea, vertigo. True vertigo is that classic room spinning symptom where you really feel like your entire world around you is spinning. Whereas imbalance might just be like, oh, things look a little shifty or out of place. Your head might feel fuzzy. I had a guy, I was treating the wife, but the husband kept saying, oh, I have dizziness. I have dizziness. Can you evaluate me? Can you evaluate me? So I said, I'll take my best whack at it. And then if I can't solve it, I'll send you to a vestibular specialist. So I started with him. And the most interesting thing, when I asked him to describe it in other words, he actually didn't have any of those symptoms. His primary symptom was actually nausea.
Huh.
So yeah, but to him, it felt like dizziness. So dizziness is a big umbrella term. Try to be specific with it. There are two main different causes of dizziness when we look at our body system. So there's peripheral or central causes. So what that means, let's see, how do I want to explain this? I'm going to talk about the central nervous system first. So anytime we talk about central versus peripheral, does everyone have an understanding of what those words mean? Sort of, kind of?
Yeah. Sort of,
So,
kind of.
okay. So central is more closer to the center. Peripheral is more out there, like farther away. So you'll hear these terms like with peripheral vision, it's kind of like your main vision is what you're looking at. Your peripheral vision is like, what can you see on the outskirts? So if you want to think of central as like closer to the middle, peripheral is kind of farther away. Now, when we talk about the central nervous system versus the peripheral nervous system, the central nervous system is your brain and your spinal cord. That's it. Brain and spinal cord. Those are like the motor, okay? And then the main highway. Whereas the peripheral nervous system is all the nerves that come out from your spinal cord and go to your fingers, your toes, your torso, they go everywhere. So got brain and spinal cord as your central nervous system. Peripheral will be the nerves that come out from your spinal cord and innervate the rest of your body. So along those same lines, you can have central causes to your dizziness or peripheral causes. So a central cause would be anything really mostly affecting your brain. So there are certain types of dizziness that can be after a stroke that may not ever go away. They're chronic symptoms after a stroke that present as dizziness. So that would be like a central cause. Whereas a peripheral dizziness issue would be like your inner ear. So your vestibular organ is outside of your brain. So it's outside of that central nervous system. So it doesn't necessarily always mean this, but when we think of peripheral, it's a little more benign, I would say, or it might be have the potential to be shorter lasting. So with central causes, there are treatments, but there might not necessarily be a cure to it. So you can get desensitized, you can get adapted to the dizziness or strategies where you can kind of compensate and become adapted to that, where with peripheral causes, sometimes they can be cured, if that makes sense. So the interventions for any of these really are starting with physical therapy. If you ever have dizziness and your generic PT, most PTs are trained to be generalists, but nowadays more and more all the time people are specializing and getting into niches. So vestibular physical therapy is a niche where these people, all they do is work with central and peripheral different types of dizziness, vertigo. So they'd really be the ones that you'd want to go to if your PT can't really get at your dizziness the way that you want them to. Also talk to your physician. There may or may not be medications. There's medications that can, it's kind of like the medications that you would take for seasickness. So some of those can help, but it's more like a Band-Aid rather than truly fixing the problem. So I'm biased because I'm a PT, but I regularly send my patients to vestibular specialists once I can't get them any better. The other people that are involved in this kind of team are audiologists. That has to do with your hearing, ear, nose, and throat doctors. They will do tests on your vestibular organs. So I went to one of these appointments because I had never seen it before. They blow hot and cold air into your ear and see how your vestibular organ reacts. They have these like goggles on your eyes that look at, there's a symptom that they can see in your eyes. It's like your eyes twitching. So they can tell if it's a positive or negative result. They do a lot of visual testing. So when I went to this guy's appointment, like he was having to track something on the wall left and right a bunch of times. And so they do very, very thorough testing. And
Do you
then
use Dr. James Atkins
where is he at?
Celebration?
That's who you use?
He's the best.
Okay, good to know. I'm gonna write that down. Dr. James Atkins. He's an
He's the
ENT.
best. Yep,
It's worth the drive.
yes.
Okay. Best.
And because knows he's far, he will, once you see him once, he does all the testing all at one visit. And
Cool.
then he will work with you by telephone.
Okay, good to know.
And you don't have to go back until insurance makes you 2 years later.
Okay, cool. Thanks for sharing that. The one that I tend to use just because of my location is it's called like, they have such a long name. It's crazy. It's like the Ear, Nose, and Throat and Plastic Surgery Associates of Winter Park or something like that. And they have a whole system. They are connected to what's it called? Not a chain, but a franchise.
Mm.
There's a company called Physical PT, which is a franchise, and one of them is located in Winter Park. And so they collaborate with this group of ENTs to do vestibular evaluation and treatment. So,
Well, I went to 4 different ENTs that couldn't figure out what was wrong with me until I went to Dr. Atkins.
okay. So, yep, I know how that is. You found your guy. Cool. So let's see, we got hearing, and that's it. So again, we're thinking of all of this as it pertains to balance and fall prevention, fall risk. So hearing is interesting. I will be doing balance testing with somebody, and if there's a loud noise, or not even testing, just training, I'll just be in the middle of a session with them. If there's a loud noise, it can throw their balance off. Back when I used to work in a hospital, when I'd be working with somebody and someone would pass by in the gym and say, this also, I'm thinking comes into play, especially when the patient's eyes are closed, where so their vision's not really distracting them. It's making it harder for them to balance, but when the only change is an auditory input, like a loud noise, they'll totally be thrown off balance. I don't know if that's ever happened to you, but hearing definitely plays into your balance. You know, if you hear a train, the sound hits, say a train's coming over from my right side, the sound hits my right ear before it hits my left ear. So that's how my brain can tell that it's coming from over there as opposed to somewhere else. So if you do have hearing loss or tinnitus, that's another really common one.
I have tinnitus and I have had for years.
Ugh,
I
feel
have both.
ugh,
Me too.
terrible. You would think that if you had hearing loss, you wouldn't have tinnitus. 'Cause
They actually go hand in hand. It's pretty common.
yeah. So double whammy. But that will definitely, I mean, if you think of it, another way that it can relate to balance, if you constantly have this ringing in your ears, you might not hear a car approaching you on the side, or if you're in the grocery store, you might not hear someone coming up on your right side. And so it's just about like knowing your surroundings, and like spatial awareness might be decreased if your hearing is decreased or if you have tinnitus. So difficulty, okay, these are other concerns. Not all of these pertain to fall prevention, but difficulty receiving and understanding important information such as health, financial, and legal information. So it can also lead to avoidance and isolation socially, and then safety concerns, for example, hearing a car horn, a smoke alarm, or ambulance sirens when you're driving. I have a number of patients who, the first one, where like not being able to receive that health and financial information, really, I've seen it a lot where I can be explaining something and there's just a disconnect because they're not picking up every word. They don't want to ask a million times, what, can you say it louder? Can you say it louder? I saw this actually the other day at my sister's wedding. There's a family member that we have that is on his way to being fully deaf, and he just can't contribute a lot to conversations. It's kind of sad. And so yeah, hearing can definitely play a big impact. Do any of you have hearing aids?
I did. I need to get them again. I lost one and I need them. And they do work and they help me with the tinnitus as well.
Really?
Yes.
Okay, because I would love your perspective. I have a number of patients that hate wearing hearing aids, and I'm like, is it just the brand that they're using? Is it not a good fit? Is it just what is going on? Because
It's very complicated. Carol or Bonnie, do either of you wear hearing aids?
Yes.
Oh, no, my mother did and my dad.
Well, first of all, Amber, there's, I don't want to say psychological, but there is an emotional attachment having to do with hearing aids because this is my impression, and I've talked to other people and they feel similar. It's like when you realize you need glasses the first time. Oh no, glasses? It's that same type of thing. Oh no, hearing aids?
oh,
So part of it is not even wanting to acknowledge it. Part of it is it takes a while. It's not like you get the first pair and they might be perfect. You might have to wear them for 6 months before you finally go, oh, okay, I'm starting to get the benefit now. And they can hurt, they can be uncomfortable. For me, the benefit outweighed any downside to it, but it took me a while to get there.
okay.
I had my gal give me all sorts of earpieces, different shapes and sizes. And then I just played with them until I found ones that worked for me.
Okay.
And then that was it.
And they
Those were the
worked
ones,
well.
those were the ones that worked, and that was it.
Cool. I've
But
seen a number of times where, especially if my patient has a family caregiver, like a child or a spouse, and it's like such a point of contention with the patient doesn't want to wear them, the spouse or the daughter, like the child just is driven crazy because they're like, wear your hearing aids, and they're like, I don't want to wear my hearing aids, and they just battle about it, and I'm like, what is this about? Just wear them or go get them fixed. Like, shouldn't it help?
It's like I said, it's multi-layered for
Yeah,
different people. It really
yeah.
is.
I mean, that totally makes sense. I feel like we can have a positive age stereotype, and we can have grief or sadness about things changing in our bodies. So yeah, that totally makes sense. Um, so intervention, hearing aids, telephone amplifiers, or technology that changes spoken words to text. Nowadays, the the audio options that are available to us are so awesome. Like, I just feel like with the technology age, it has really opened up a lot of options that weren't there for people before. So there are phones that have a screen, and it's the whole thing can be written in text, or like automated captions on any video we watch now. YouTube, most videos on YouTube have like the automated captions. Captions are really common on TV and movies nowadays. I don't know if your cell phones do it, but if someone leaves me a voicemail, it shows me a preview of the whole voicemail written out. So these are, adaptation or compensations, or just a different way to intake the information, that are really helpful now to people that are hearing impaired.
And
Ask
and
people.
having the captions on the TV, at least, more and more people I see have them on all the time.
I
They
know.
so they keep the volume down. They don't have to have it blasting, and yet they can keep up with the show. I
Yeah.
don't know if it
I use,
distracts you from the show, but
yeah, I use the captions.
yeah,
Particularly if I'm watching a British show, I can't always catch that
that's right. The
accent,
accents.
and I just leave it on all the time.
Yeah, the
I do
accents.
too. I can hardly watch anything now without, I've grown accustomed to knowing every single word that they say.
Yeah,
That
yeah.
if I miss a word, yesterday, I was watching a movie, and I actually rented a DVD from the library, and it started without captions. because it wasn't on Netflix or something. And like 20 minutes in, I put the captions on because I was like, I want to know every single word they're saying. You can ask people to speak in a lower tone. So a lot of people with hearing loss, I'll do this if I lower my voice and try to talk a little deeper, then they'll usually, instead of, sometimes you accidentally get into, hey, how's your day? Da, 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 and you're kind of talking up here. Whereas if I lower it, for some reason they can hear better. Because I guess it has to do with the different decibels and pitches that are lost first, so they lose the higher ones first. Speech reading is the like medical name for when, like, lip reading. So you can ask people to turn to you and face you when they're speaking. Who did I have? I had somebody. Yeah, just I think this was really difficult during COVID when people had to wear masks, that people would be like, can you pull down your mask? I can't see your lips when you're talking. Being aware of your environment. So if you go to a restaurant, don't sit next to the kitchen or a live band. There's an organization in Orlando. It's like a nonprofit little volunteer operation, but this guy that I network with, he has a list. It's growing. Right now, I think there are 4 or 5 restaurants on there that have good environments for people that have hearing loss. So they either have a certain section of the restaurant that's quieter, or that's usually what it is there's some section that is intentionally quieter.
Wow.
And so they have been willing to partner with this guy and say, yes, we endorse, we are in support of what you're doing, and we will like cater to people that are, have a hard time hearing. So that's cool.
Very cool.
I'd like to know that list.
Yeah.
Yeah, I can look it up. Aunt Law, I think all the restaurants are in Orlando.
Oh, well.
But they might have
Something similar. They might.
something
Yeah.
similar. And then if not, you can just be aware of it. And also just knowing you can always ask restaurants to turn the volume down of music. They might not always say yes, but sometimes when I've gone to study in a coffee shop, the music is surprisingly loud.
Yes.
Ask them to turn it down a little bit. Usually they'll accommodate you and do it. Or they might sit you a little bit in an area that's, they know where the speakers are, so they can sit you away from the speaker. Turning off background noise, like turning off the TV when you're trying to have a conversation with somebody. That's just too much input coming at you at once. I am very sensitive to that. So I always ask my patients, can I mute your TV, please? And it's distracting for everyone involved. Like if they have their TV on, even if we leave it on, I might be distracted while they're doing exercises because something flashed up on the news and I'm reading that. And it's like, we're just humans, we're distracted. So, that can help you hear better with the people that you're with. Smart technology for hearing impaired that use visual indicators such as flashing lights. So a lot of phones, if your phone is ringing, you can have the flashlight flash while it's ringing. And same with like alarms. I believe they have doorbells now that have that. I don't know where the visual indicator lives, but that is a very cool invention. Getting your ears cleaned. So most people do tend to have a buildup of earwax that needs to be cleaned out at some kind of regular interval. And then cochlear implants. Those would be a more invasive, severe option.
That thing about the earwax, Amber, that's no joke.
Really.
I took my mom, we went to get her hearing aids the first time, and they showed us the whole process. It really is amazing how much gunk gets built up in there and they can pull it out.
That's so cool. I'm
I mean,
wondering
it's kind
now.
of gross, but it's also good to know because it automatically she could hear a little bit better. So
Yeah. I'm wondering what age they start recommending that at. Like, if I went and got my ears cleaned, I'm sure there's be gunk coming out, right?
I don't know when
It all depends. I don't build up earwax, but a friend of mine, she grew earwax like crazy.
yeah, some
It's all
people do.
it's all
I do.
individual.
Yeah,
It says you should only seek medical help for earwax removal if it's causing problems like hearing loss or pain. In general, try to avoid removing earwax at home. I'd have to look into it, but that's yep. I've had a number of patients that do that and say it helps a lot. So
really, it really does. Yeah.
mhm. Okay, so we went over medications, vision, orthostatic hypotension, dizziness, and hearing. Carol, just you, if you don't get a chance to watch the replay, I started off just by saying, let's zoom out. And if we're looking at fall prevention from that bird's eye view again, we're going to start with exercise, home safety, medications, and vision, and then the rest of the fall risk factors. So we've already covered exercise and home safety. Today we covered meds, vision, and now we're starting on the rest of the list. So yeah. Any questions?
I have two, if I
Yeah.
could. Back under medications, I think at one time I asked you this and I forget where we ended with it, but I have osteoporosis and they want to put me on Prolia or
Oh, yeah.
Evenity. Either one of them is to build up, help to build up bone mass. It supposedly helps you prevent breaks if you fall. I'm just curious at some point if you have any input on that type of medication. Is it worth pursuing? I don't want to start taking something and then find out a year from now, oh no, that's terrible. Like way back, Fosamax was that way.
Yes.
Personal experience. I did the Prolia one time,
Yeah,
and it's a every 6 month thing,
right.
and uh, and it's 6 months because it stays in your system for 6 months. And I suffered untold side effects
Ooh,
the entire 6 months.
okay. Well, thank you. I'm glad I brought it up.
And one of the side effects, and you'll see it on TV advertised all the time, about severe hip, thigh, bone pain, whatever.
Yes.
The pain was so bad, I thought I rebroke my pelvis.
Wow.
Yikes.
And I went and had my pelvis re-x-rayed because the pain was as bad as when I broke my pelvis.
Oh my
Unbelievable.
God.
I
Right.
have,
And
I
it
have,
stayed that bad for the entire 6 months.
Mm.
Really?
And there were
I
like
have,
15 side effects or whatever. And I had like almost all of them.
Wow.
And needless to say, I didn't do it again, and
Yeah.
I didn't do anything after that.
Well, this is why I ask. You talk about being an advocate. If you don't ask, you don't
I
hear.
take 1 a day for calcium, no side effects.
let me tell you my experience. I've been doing Tai Chi now for a year and a half. And last year, my doctor wanted me to have a bone density, and my bone density had gone up. And he said it was the Tai Chi. And I'm also thinking this Otega, moving your legs and your feet, like you've said, Amber, that's how you help build stronger bones. And it's amazing, that you can do something like that and build your bone density back. Because I figured at my age, I was really surprised when the numbers came back.
That's great.
And
So
I did, and I
I
can't.
was, go ahead.
Go ahead.
Go ahead. What do you want to
Try
share?
something, I would try something like that first before I started that shot or whatever, like
Okay.
Cheryl was saying that she had a problem with. Try to do as much of this Ortega as you can. You can go on YouTube and see Tai Chi. It's a very gentle exercise, and I couldn't believe it. And that's the only thing I've done different.
Hmm.
Yeah, so with those injections,
Mm-hmm.
what they've shown is they have a short-term increase in bone density, but in the long term, there's not really a long-term benefit.
Okay.
So they might increase it acutely, very quickly. But long-term, really the answer is exercise and nutrition. So it's kind of that idea of like, regardless of what quote unquote diet you're doing, or, you know, hopefully we're not dieting or just eating a certain way, but whatever lifestyle decision you're making for your nutrition, the common denominator is that they all have whole foods. So there's paleo, there's carnivore, there's Mediterranean, there's vegetarian, there's whatever. The less processed you can do, the better. And almost everything is processed. I will also say I'm learning more and more about this all the time, but most of the FDA guidelines for what we're supposed to do in the way of nutrition are paid for by food companies. So there's a conflict of interest there. And so definitely do your own reading. You got to not go too far down the rabbit hole so you don't, you know, think that you're not safe to eat anything. But even stuff like canola oil, seed oils that we always thought were healthy, really not. Just again, anything processed. So if you take an almond and crush it down, you get crushed almonds. If you crush it more down, you get almond milk, almond butter. But if you look at the almond butter and the only thing in it is almonds, you're good, right? But that's just like an example of processing where if the package has ingredients that you can't pronounce, that's a good indication. So we don't
Yeah.
need to overthink it. I can tend to go too far down the rabbit hole of,
Okay.
you know, so nutrition. And then I've heard it said, this was from, he was a chiropractor, but he has a ton of YouTube videos on metabolic function and dysfunction, and he has a good way of explaining more of like the bird's eye view of how our bodies work. And he was like, supplements are great, but if your diet consists of fast food and processed food and you're putting supplements on top of it, that's not going to do anything. Supplements are a more subtle treatment. They work, but that's on top of an already solid foundation of nutritious food. So, and then
So
exercise. Yeah, go.
what if you, I'm going to be very honest. What if I mean, I kind of have a combination. I do believe I eat healthy and I have fruit and vegetables and salad and whatnot, but I also eat some processed foods. I don't know if it's 50-50. I guess I should stop and take a look at that. But yeah, I do eat some processed foods. I mean, even cheese. I guess I should look. Some cheese can be processed.
Yeah. Yeah.
It's hard.
So
Yeah.
it depends on your goals in your life. I've heard stories of people with cancer, people with any number of chronic conditions, diabetes, that don't change their diet. They don't want to. They don't have any interest in it.
Yeah.
So they're allowed to choose that. If you want, you know, certain foods in your life. I struggle with this too. I'll just be very open. I have struggled with an eating disorder for a long time, and I've gotten treatment for it. I'm still getting treatment for it, and it's getting better all the time, but it's one of my big life's hangups. It's one of my, you know, assignments in my lifetime is to work on this. And So, I get it. And so, I have friends and stuff, they're just not willing to make those changes, and that's okay. You're allowed to have a life with, if that's, the pleasure you get from that and stuff like that. So it
Yeah.
just,
It's emotional eating a lot of the times.
Yeah.
It's stress or whatever.
yeah. So I'm going to be the last person to tell anyone they need to eat a certain way, because
It's
for
hard.
me, it has started impacting my mental health so much that now I'm motivated to do something about it. So most human beings are more motivated by pain than by like prevention. So it's
Mhm.
like, oh, I'm eating a certain way, I'm going about my life. Oh, now I have diabetes. Now I'm going to do something about it. When
Right.
really we probably knew a long time before we were diagnosed with diabetes that we should eat differently.
It was
So,
coming. Yeah.
um, so yeah. Okay,
Okay.
did you have a second question?
My second question was just, you were talking about compression stockings. I mean, I've never used them. I don't know if it's something I should look into, or maybe I don't need them yet.
Like, who needs them? Is that your
Yes,
question?
yes. What is it good
So,
for? I get restless legs at night. Is it that type of thing?
so restless legs, I think it's more the position and the being down. You could certainly try it, being horizontal for an extended period of time. Um, so people with swelling in their legs, that's a really good indicator to try compression stockings. And then people with chronic low blood pressure.
Yeah, okay.
Um,
I don't have that, so.
yeah. So those are the main two that we start
Okay.
with. Yeah.
I have kidney disease, so I have swelling with my legs with the kidney disease, so I use compression hose.
Okay. Yeah.
But I find the more active I am, the less swelling I have.
Yeah, absolutely.
So then I don't need them as often.
And
That's
then nutrition there too. I mean, they say less sodium, that'll hold, and less refined with swelling, less, like fast food eating out tends to have a lot of additives and stuff. So I've noticed this one restaurant in particular that's a fast food restaurant that I'll get chicken and French fries. I swear, if I eat there, I've noticed in the morning I wake up and my face is swollen, my fingers are swollen. But if I
wow.
eat a different chicken and French fries restaurant, it doesn't happen. So I don't know what they have in their food, but I could go to a Mexican restaurant with so much salt, and something in this place I just notice an immediate reaction. So pay attention to how your body
What
responds.
place is it?
Huey Magoo's.
Never heard of it, never been there.
So yeah.
Well,
So
I
you
eat
would,
salad with my Haagen-Dazs ice cream, so.
yeah. It's a good balance. It's all about balance.
That's right. That was my second question, was about the stockings.
Yeah.
Great. Well,
I'm gonna
Tai
have-
Chi, I
I'm gonna
learned
have
another
to
thing.
Go, Amber.
Yep. We're gonna wrap up here. So thank you
We'll
all for
see you
being
on
here.
Thursday.
Thank you.
I'll see you guys Thursday. Thursday, we're going to talk about how to fall and things that you can practice to help get you in the habit of to make your inclination more to like tuck and roll instead of bracing when you do fall. So
Great.
Good,
cool.
sounds good.
Bye, everybody.
Hang
Bye.
out a second, Amber.
Okay. See you guys Thursday. What's up,
Okay.
Carol?
I wrote to you yesterday